often involving excessive purchase of specific items, even items that might be considered atypical or odd. Compulsive eating being another problem of new onset food cravings, often involving sweets or pasta, nocturnal binging, and often occurring with other impulse control or other mood disorders. And then there's another problem with dopaminergic medication abuse. This is the inappropriate and excessive use of anti-Parkinson's medications with drug-seeking behaviors and tolerance and dependence. And often these patients will have a distorted perception of their on-off motor and their mental states. During the on states, they have intense high, euphoria, increased libido, pressured speech, and during their off states, dysphoria and irritability. Along with this, you may see other impulse control disorders. You see patients with other concurrent mood disorders at times, with the prevalence being up to 4% in patients with Parkinson's disease. Last is the problem of punding, which is the intense engagement in stereotyped and repetitive performance of useless tasks, such as handling or sorting or examining or assembling and disassembling objects, such as sorting buttons, shelving books, repetitive singing, or cleaning. These behaviors are often calming to the patient and difficult to stop. It can be associated with overuse or high doses or abuse of the dopamine replacement therapy. And often there can be associated hypersexuality and gambling or the other abuse of medications. And the prevalence being up to 14%, often occurring more when there is some cognitive dysfunction. These impulse control disorders are not necessarily a feature of a manic episode. They seem to be independent of manic episodes. In our series, and I won't go into the details of this, but essentially patients with bipolar disorder seem to be separate from these patients with impulse control disorder, although there is considerable overlap among the features of mania and these impulse control disorders. So briefly to go over the treatment of the neuropsychiatric disturbances, the general approach is what you want to do is have a targeted and individualized approach. You want to make sure that you have adjusted or optimized the anti-Parkinsonian regimen and treat the medical conditions, and delirium in particular, urinary tract infections, etc., and make sure that the patients aren't taking medications that they don't need to be taking, such as pain medications, other anticholinergic medications that might, for example, be used for treating urinary incontinence if they really aren't necessary. And then to use specific medications as needed for treating specific psychiatric symptoms, as well as to use non-pharmacologic treatments. Education is, by and large, the mainstay of treatment of the psychiatric aspects of Parkinson's disease. Many patients and their families need to be educated about the common occurrence of these psychiatric complications, because they don't realize that Parkinson's is not just a movement disorder, but it's accompanied by cognitive and mood and other psychiatric complications that we've been discussing. Psychotherapy can be invaluable for many patients, especially early in the course of the disease, and many types of psychotherapy can be helpful, as well as caregiver support. The rehabilitative therapies go a long way towards improving function, and when patients have improved function, they can often cope better. But again, if you don't treat the depression, that will trump coping. Social supports are very important. Patients need to be encouraged to take part in support groups, and home care can be invaluable for helping to provide rehabilitative therapies, as well as a source of support and education for families and patients, as well as provide additional insights for the clinician who's caring for the patient. Often what we talk about in Parkinson's disease management is this the motion-emotion conundrum, which was described by Jeff Cummings in an article in the New England Journal of Medicine when they were talking about treating psychosis in Parkinson's disease. What we want to do is maintain adequate motor function, but also control the psychiatric symptoms. And often the two can be at cross purposes, because many of the Parkinson's medicines can cause psychiatric symptoms, as we've mentioned earlier, but the medicines to treat the psychiatric problems can also cause motor symptoms. So, for example, the antipsychotics, particularly the dopamine blocking agents, can cause motor dysfunction. But antidepressants have also been reported to cause some Parkinsonism in some patients. These are just a series of antidepressant treatment trials that often have not been very, have not shown been shown to be typically terribly beneficial, at least in initial studies. And these are studies looking at paroxetine, nifazodone, citalopram, showing that there wasn't tremendous benefit of the medication relative to placebo. More recently, we've had some studies looking at dopamine agonists that showed that it may be helpful for depressive symptoms in Parkinson's disease in the absence of actually major depressive disorder. So the dopamine agonist can be helpful for depressive symptoms, but not necessarily as a definitive treatment for major depressive disorder. Recently, placebo-controlled trials have shown that the tricyclic antidepressants have had efficacy, with one study showing that desipramine having greater benefits than citalopram or placebo in the treatment of depressive symptoms in patients with major depression. But over several weeks, desipramine and citalopram both showed superior benefits relative to placebo. And then in another study recently, looking at nortriptyline, it was shown to have greater benefits than paroxetine as well as placebo in an 8-week clinical trial, in which there were both improvements in quality of life as well as in disability, in addition to the depressive symptoms. And staying on the active drug was associated with reduced relapse relative to placebo treatment. So as we've mentioned before, many patients will be partially treated for the depression, and what we really want to achieve is remission of depression. So it's important to follow the patients and treat their depression to the point of remission and resolution of those depressive symptoms, and not just to have some improvement. Important side effects and interactions to be mindful of are the potential for hypertensive crises or serotonin syndrome, particularly when patients are taking selegiline or rasagiline. Orthostasis, GI upset, sedation, anticholinergic side effects with certain antidepressants, as well as if you're using benzodiazepines, they will have side effects, in particular cognitive side effects. Increased Parkinsonism can occur with antidepressants in some cases, lithium, sodium valproate, amoxicillin, and of course with the dopamine-blocking neuroleptic agents. CBT, or cognitive behavioral therapy, has been shown to be effective for in one treatment trial for depression in Parkinson's disease, and I won't go over the details of the study for the sake of time, but it is a useful treatment option for patients who have not had complete remission of their depressive symptoms with good trials of antidepressants. Apathy, possible treatments, certainly it's largely non-pharmacologic, is that what you need are what has been described as goal-directed, reality-based, paternalistic approach with the caretaker as the auxiliary executive. So often it's the caretakers who need to provide the patient with structured activities